Thank you for joining for the Red Blood Cells and Anemias lecture for the Hematology and Oncology unit of the General Medicine course. Please be sure to have your study guide with you during this recording so you can complete that. Please be sure to review the objectives for this lecture so you can be prepared for the exam. We will begin by discussing blood cells in general. So blood cells are divided into three different cells. The red blood cells are erythrocytes, the white blood cells are leukocytes, and then the platelets or thrombocytes. And just to see here below, there is a smear with some examples. You can see specifically the red blood cells. Examples are here. Then you have different white cells. You can see a variety of different ones, eosinophils, lymphocytes, and neutrophils. And there are several other white blood cells. And then also examples of platelets are here. When discussing blood cells, specifically red cells, it's important to make sure you are familiar with the different types of tubes that can be used for blood collection. There are a variety of them listed here. Please make sure you are familiar with the ones that are in bold. And the most important ones to be familiar with, for example, red tubes, and the color can vary, but is pretty consistent. Red tubes have no additives to them, and these are used mostly for chem panels, testing for bilirubin, some of the kidney testing, as well as testing for calcium. The purple or lavender tubes have EDTA, which is an anticoagulant, and this is used for doing tests such as the complete blood count or CBC and platelet counts. Green tubes have heparin, usually they're lithium heparin, and these also are an anticoagulant, so it prevents clotting. These are also used for chemistries and for certain ammonia testing. And the last one that I want you to be familiar with would be the blue tubes, which are full of sodium citrate, which also prevents clotting and is used for PT and PTT, which are blood clotting tests. Let's start by discussing red cell testing. First, we'll discuss the red blood cell indices. Red blood cell indices are mean corpuscular volume, mean corpuscular hemoglobin, mean corpuscular hemoglobin concentration, and the red cell distribution width. We'll discuss each of these in the coming slides. Mean corpuscular volume, or MCV. The mean corpuscular volume is a measurement of the average volume per red blood cell. The normal value for a mean corpuscular volume is between 80 and 100 femtoliters, spelled like this. And if you have measurements of cells, you're going to base it off this normal. So if the cell is between that 80 and 100 FLs, then that is a normocytic cell. If it's less than the 80 femtoliters, it's considered microcytic. And if it's macrocytic, it is greater than 100 FLs. And you use these measurements for classifying anemias. We'll be discussing them further later. Mean corpuscular hemoglobin, or MCH. This test is used to look at the average content of hemoglobin per red cell. So this is per single cell. And the normal range for this is 26 to 34 picograms. Mean corpuscular hemoglobin concentration, MCHC. The mean corpuscular hemoglobin concentration is the average concentration of hemoglobin in a certain volume of red blood cells. For these, they're classified as either normochromic or hypochromic, with the normal values being between 32 and 37 grams per deciliter, and anything under that 32 would be considered hypochromic. The last value we'll look at for red cells is the red cell distribution width, or the RDW. The RDW looks at any variation in the red cells as far as size and shape. Typically, if you have a patient who's non-anemic and is not having cell breakdown or hemolysis of their red cells, all of their red cells should be the same size. If there are problems such as anemia or hemolysis, where red cells are breaking down or red cells are smaller or larger than they should be, the RDW will increase, meaning that there's a larger difference between the size of one cell and another. This is usually due to problems such as anemisocytosis, which is variation in size of the cells, or poikilocytosis, which is variation in the shape of the cells. Our normal range for RDW is 11.5 to 14.5. As there is more difference, you will see that RDW increase. We'll also discuss some other red cell tests besides the red blood cell indices. These all involve reticulocytes, which will be the reticulocyte count, the corrected reticulocyte count, and the reticulocyte production index. We'll discuss those each on their own slides. Reticulocytes are immature red blood cells, and they're identified by a couple different features. They are larger than red blood cells, and they also have residual ribosomal RNA. As red cells mature, they actually do not have a nucleus, and there is no remnants left in there. When you do a reticulocyte count, you're looking at the number of reticulocytes in 100 blood cells. So normally your reticulocyte count should be about 1 to 2 cells of those 100 in a non-anemic patient. The reticulocyte count is used to help differentiate between different causes of anemia. The two different causes can be either problems with production or problems with destruction, and we'll discuss those further in other sections, but some examples are listed here for you. Corrected reticulocyte count. In cases where a patient is anemic, they're going to be releasing reticulocytes more often compared to a non-anemic patient. So there is a correction done for the reticulocytes. So you take your reticulocyte percentage times the hematocrit over 45 to give you that corrected count. Reticulocyte production index, or the RPI. Normally reticulocytes are only in the circulation for about a day, and then as they mature they become a red blood cell or erythrocyte. If you have a patient who's anemic, the reticulocytes are released early from the bone marrow and they don't mature as quickly, so they may be in the circulation for much longer, sometimes up to 2 to 3 days. This causes a shift or a left shift in the red cells, and it's something that needs to be corrected for, and that's where the reticulocyte production index comes into play. You take the percentage of your reticulocytes, and then like the correction index, you multiply it by the hematocrit over 45. But there's also a correction factor, so 1 over the factor. You take the patient's hematocrit, which is listed here, and you correct it based on what the hematocrit is. You can see examples here of different values and what correction factor you're using. Once you have those values, you can calculate the RPI. And if your RPI is less than 2.5, there's an issue with hyperproliferative anemia. And if the RPI is greater than 2.5, there's an issue with hyperproliferative anemia. So again, just to review, the RPI is going to give you a better idea of how well the bone marrow is functioning. If it's a hyperproliferative anemia, the bone marrow is not able to compensate. Therefore, there's low reticulocytes despite the anemic state. If you have a hyperproliferative anemia, the bone marrow is compensating and pushing out more reticulocytes. We will discuss the reticulocyte production index a little bit further in some of the sections on anemia. Now that we've discussed the red blood cell indices and the reticulocyte testing, we'll now look at some examples of red blood cell findings on the peripheral smear. The first peripheral smear finding we'll discuss is hypochromic microcytic red cells. For these, you have very small red blood cells, microcytic, and you also have prominent central pallor, so hypochromic, not much color to them. Hypochromic microcytic red cells are due to problems with hemoglobin synthesis, specifically diminished functioning of hemoglobin synthesis. If you're seeing an anemia that is hypochromic microcytic, the first thing you should be considering is iron deficiency. That is the most common reason for this type of anemia. There are some other considerations, thalassemia, sideroblastic anemias, and anemias of chronic disease, and we'll be discussing how to differentiate these in later slides. On the smear below, you can see lots of examples of different red cells with pretty significant central pallor. So you can see here mostly white, not much color there, a lot of pallor. And you can see varying amounts. For example, this one, not as much pallor. But in general, you should be seeing about 1/3 or so of the cell may be white, and then the rest of it should be red. Target cells on peripheral smear. Target cells have a obviously target-like appearance of the red blood cell. Very often these cells are also hyperchromic, or they have some pallor as well. This is an issue due to increased membrane redundancy. For these, the primary thing you should be considering and thinking of is specifically thalassemia. And some examples of the target cells on here. So there's one here, there's one there, example there, example there. And again, these are going to be very typically seen in thalassemias. Spherocytes on peripheral smear. So this is a very spherical or a round red blood cell. They do not have any pallor, as you can see in the image down here. They appear very dense, again, not much pallor. And this is actually the opposite of our target cells. This isn't due to increased membrane redundancy, but due to decreased membrane redundancy. And the primary thing you should be thinking of when you see spherocytes, the first thing you should be thinking of is hereditary spherocytosis. You can also have spherocytes in other issues such as the immune hemolytic anemias. And some great examples of many, many spherocytes in the image below. Elliptocytes. So these are elliptical shaped red blood cells, and they have a problem with one of their proteins. Specifically, in many cases, this is spectrin. And often you will see this in a hereditary syndrome called hereditary elliptocytosis. You may also see some elliptocytes in other anemias, especially iron deficiency anemia. And some great examples of the elliptocytes in the image here. Stomatocytes on peripheral smear. Stomatocytes, so stoma meaning mouth. So stomatocytes are mouth or cup-like deformities of the red blood cells. And this is also due to a membrane defect. It could also be seen if the blood smear was very dehydrated, so problems with drying the smear properly. Most common reason you'll see this is if it isn't an artifactual issue is from hereditary stomatocytosis. You can also see this with liver disease. And again, some nice examples on the smear below of stomatocytes. Teardrop cells on peripheral smear. These are red blood cells that are in the shape of a teardrop. And the most common reason you'll see these is myelofibrosis. We'll be discussing myelofibrosis in upcoming lectures. Another reason you might see teardrop RBCs could be some other space-occupying lesion of the bone marrow, so like a bone marrow tumor. And some great examples of teardrops on the image below, right here. Burr cells or echinocytes on the peripheral smear. Echino, which is right here, actually means sea urchin. So if that is helpful for you to remember what the name means. These are red blood cells that have very short but evenly spaced and evenly sized spicules, so little spikes coming out of it. But this evenly spaced and sized is important. This is due to a membrane issue with the lipids. And it could be a reversible defect, meaning that it could come and go, and this could be related to different metabolic states or other chemicals that could be present. It may also be seen in chronic issues such as renal disease, specifically end-stage renal disease, and metabolic issues such as PKU or in liver disease. You can see some examples of some echinocytes here. As you'll notice, there are still some normal cells mixed in with these echinocytes. And that's important to know because that would be a true echinocyte. If you have something where you could have a pseudo-echinocyte, these are actually called crenated cells. And all of the cells, as you can see in this image here, have that echinocyte appearance. But this is not actually true echinocytes. This is actually caused by extra EDTA in the tube. So what does that mean? The tube wasn't filled enough. There wasn't enough blood to equal out the amount of EDTA that was in the tube, so there's excess EDTA. It could also be for other reasons. The slide was dried, too quickly, or maybe there was too much humidity, or there was a problem with pH, and you could get this appearance right here, the pseudoechinocytes. Acanthocytes on peripheral smear. Acantho means thorn, and these are again spiculated red blood cells, but they have projections that are of varying lengths. Again, it's due to an altered membrane lipid issue. You can see this type of cell after a splenectomy, from anorexia nervosa, from hypothyroidism, or from liver disease. Schistocytes on peripheral smear. Schistocytes are distorted fragments of RBCs. So that means they're pieces of RBCs. Usually they have about 2 to 3 points on them. So you can see some nice examples down here of different little schistocytes. So these are actually torn apart red blood cells. So you can see this is due to often some sort of mechanical distortion. In some examples, microvascular fibrin strands, these are often caused by something we'll be talking about in another lecture called DIC or TTP. DIC is disseminated intravascular coagulation, and TTP is thrombotic thrombocytopenic purpura. And both of these involve fibrin clots, and those clots actually tear apart or shear those blood cells apart. You can also see something similar to this with prosthetic heart valves, and often you can see this in patients with severe burns. Sickle cells on peripheral smear. These red blood cells have a sickle shape, meaning this shape here. You can see a couple of them here. And this is due to an aggregation or collection of hemoglobin S. We'll be talking about this later when we talk specifically about sickle cell disease. So some of the different sickle cell disorders that you'll see, you'll have sickle cell SS, the sickle cell SC, and then you also have the S thalassemia or SB is the other variant. Please remember that you won't necessarily see sickle cells in sickle cell trait. There are some cases where you might, and we'll discuss that later. Howell-Jolly bodies on peripheral smear. These are often abbreviated HJB. The Howell-Jolly bodies are a small piece of basophilic nuclear inclusion. So what does that mean? Basophilic meaning it stains easily, and nuclear inclusion meaning that it's still being retained by the cell. In this case, for the Howell-Jolly bodies, these are a DNA remnant, most commonly caused by either a spleen that's been removed or an underactive spleen. You could also see this with hemolytic anemias or other megaloblastic anemias, which we'll be talking about later. What happens with the Howell-Jolly bodies is normally they're produced in the red cells, but the spleen is really great at finding these abnormal cells and removing them fairly quickly. If you have issues where you don't have the spleen or you have an underactive spleen, that obviously explains why they're not getting removed. But in the cases of hemolytic anemia or megaloblastic anemias, if they're very severe, there's a left shift in the red blood cells. So you're going to have more immature red blood cells, which are more likely to have the Howell-Jolly bodies. And if they're in severe cases, there's so many immature cells that the spleen can't keep up, and it can't clear all those bad cells. And a great example down here of here's the inclusion and here's the cell that has it. So you can see that basophilic nuclear inclusion, which is made of DNA in the photo here. Basophilic stippling. Basophilic stippling is a basophilic inclusion, but it is multiple inclusions, and it is usually made of RNA and ribosomes. If you hear basophilic stippling, the first thing you should be thinking and considering is lead poisoning. Could see this in other syndromes such as thalassemia or megaloblastic anemia, and there's two great examples on this smear here of basophilic stippling. Heinz bodies on peripheral smear. Heinz bodies are abbreviated H lowercase z, capital B for Heinz bodies. And this is a inclusion in the cell, but this inclusion is made of hemoglobin. And this is due to either a defective or denatured hemoglobin that gets trapped in the red cell. The most common reason to see this is from G6PD, which is an issue with oxidative stress causing the hemoglobin to denature or be damaged. You could also see this with liver disease or certain types of thalassemias. And the way to remember this and differentiate it from the Howell-Jolly bodies is that, first of all, this is hemoglobin, not the RNA or ribosomes. But Heinz bodies also are in the very far periphery. You can see they're not inside the center of the cell or on the close to center of the cell. They're very much on the very outside of the cell. And there's lots of examples in this photo here. So now that we've discussed some of the testing for the red cells, we're going to discuss all the different anemias. So what is anemia? Anemia can be low hemoglobin, a low hematocrit, and or a low number of red blood cells. Any of those would qualify, but the typical values that we'll use to determine if there is anemia is either the hemoglobin or the hematocrit. The hemoglobin for men less than 13.5 grams per deciliter, or women less than 12 grams per deciliter. And for hematocrit, less than 41% of the blood is red cells would be considered anemia, and less than 37% for women. The values for women are lower due to menstruation. As women are postmenopausal, they should be moved up to the same levels as men. Hemoglobin is your oxygen-carrying protein that's within the red blood cells, and your hematocrit is actually the percentage of red blood cells compared to the total volume. Again, the normal ranges for the hematocrit, men are going to be 39 to 49%, and women will be about 35 to 45%. Anemias are our most common hematologic disorder, and you will see them very commonly in all fields of medicine. It's almost always due to some other underlying issue, and so that's the trick with anemia, is figuring out the cause so it can be corrected. It's extremely common to see in primary care, but you can see it in a variety of different fields. And of the anemias, please remember that iron deficiency is by far the most common anemia, and it's especially more common in women and children. Again, we'll review the classifications of anemias based on MCV. So as we discussed before, we have microcytic, normocytic, and macrocytic anemias. For microcytic anemias, remember the MCV will be less than 80. For normocytic, the MCV will be between 80 and 100. And for macrocytic, the MCV will be greater than 100. In general, try to remember that microcytic and macrocytic anemias, so these two, are normally issues with production. Therefore, in general, not exclusive, but in general, their reticulocyte production index is going to be less than that 2%. In the case of normocytic anemias, in general, they are more of a destruction issue. And with destruction issues, your reticulocyte production index tends to be greater than that 2%. So this will be helpful later. We'll discuss this again when we're going over some of the different anemias and comparing them. For microcytic anemias, typically they will fall into one of the 4 types of anemia: iron deficiency anemia, anemia of chronic disease, sideroblastic anemia, or thalassemia. Macrocytic anemias are divided into 2 different types of anemia. You can have megaloblastic anemia or non-megaloblastic anemia. And for megaloblastic anemias, megaloblasts are large, immature red blood cells that have problems with DNA synthesis. So in these cases, the most common ones will be vitamin B12 or folate deficiency. And then the non-megaloblastic anemias, so they don't have megaloblasts, are usually caused by things such as liver disease, alcoholism, some other different metabolic issues, or different medications. The normocytic anemias are usually caused by 2 different things: either hemolysis, so red blood cell lysis or red blood cell breakdown or destruction, or they're caused by some sort of acute blood loss. And these can be a variety of different reasons, usually GI, but also can be surgical trauma, menstrual related, or postpartum. But remember, these are acute blood losses, not chronic slow blood losses. There also are some mixed anemias, so you could have a macrocytic and a microcytic anemia at the same time, and it could appear to be a normocytic anemia. History for anemias. When you're taking a history for a patient with anemia, there are several areas you want to focus on. The first would be the patient's age, and remember that children and young women are especially susceptible to anemia. Also making sure that you consider their sex. So obviously female patients are a little more susceptible due to menstrual cycles, and also making sure that you look at the duration of the illness. An acute anemia versus a chronic anemia is going to present very differently with different signs and symptoms, which we'll be discussing a little bit later in this lecture. You also want to look for signs of blood loss, and whether it be acute or chronic blood loss. And some of the signs you might see would be things like headache, dyspnea on exertion, palpitations, dizziness, fatigue, syncope or near syncope, and orthostatic hypotension, meaning that the patient might stand up and feel faint or pass out. Other things you want to look for signs of blood loss, GI losses, menstrual losses. You also want to make sure you look for urine loss of blood, so such as dark urine. You want to make sure that you look for any possible toxic exposures related to, for example, the patient's occupation or their hobbies or any drugs that they might be using. Very important to take a very good dietary history. Also make sure you talk to your patient about blood donations, because what happens is if they're giving about 3 to 4 units per year, that's about a 1 gram loss of iron, so a very common cause of iron deficiency. Family history, obviously, for many of the different hereditary syndromes that can cause anemia, and again, making sure you take a really good obstetrics and gynecologic history. And whenever possible, be sure to have your patient bring in all of their old lab results so you can look kind of at their baselines and get a good idea of how much change has occurred over time. There can be many different signs and symptoms of anemia, but I've listed many of the major complaints that you should be thinking could be anemia when you have them presented to you. So some of them, fatigue. Patients can have very extreme fatigue, irritability, malaise, or almost flu-like symptoms, which really pair up with that fatigue. Often you'll see either syncopal episodes, near syncopal episodes, dizziness, or what is orthostatic hypotension, where the patient stands up and their blood pressure drops very quickly. Other big symptoms you will see will be things like paleness, whether it be the whole body or especially the conjunctiva of the eyes, the lower lids. You can see colonychia, the spoon nails, angular cheilitis, so that little fissuring at the corners of the mouth. Glossitis can also be seen, which is this glossy, smooth tongue, which is due to loss of the papillae of the tongue. As far as other symptoms involving the cardiac system, you see tachycardia because the body's trying to compensate for the ability not to perfuse as much as it did previously. You may see that the patients develop murmurs as well because of the changes in the blood flow. Patients may have tachypnea because they are short of breath. They could have dyspnea on exertion. You also want to make sure that you're looking for any other signs of blood loss with those. And in the abdomen, you could see enlarged spleen or liver. If there is a problem with hemolysis or red cell breakdown, or if there's liver disease. Also with liver disease, you could see ascites or free fluid in the abdomen. For the CNS system, some anemias do cause different neurologic symptoms, the big ones being paresthesias or trouble with balance. Also for anemias, you always should be thinking that there could be underlying possible malignancy as the cause or infection, so you should be looking for enlarged lymph nodes. If you're looking for chronic bleeding, you want to make sure you're looking at a rectal exam and looking for any GI loss of blood. And then for women, you need to be taking a good history for their menstrual history and also looking for any signs of loss gynecologically. The severity of anemia. The signs and symptoms of anemia are going to vary in severity from each patient and each situation. When considering anemia, you need to think about the severity, the acuity, and also the patient's CV health. All of those are taken into consideration when looking at the whole picture. The degree of the anemia is going to tell you the degree of the disease. In general, if a hemoglobin is less than 10, most people are going to have at least some symptoms. But remember that there is not a specific hemoglobin for optimal delivery of oxygen to the tissues, so different people are going to have symptoms at different levels, and different people are going to compensate differently. When you're thinking of anemia, think of it as the following reaction. So if you have the change in hemoglobin, and you want to put that over time. And that's going to kind of tell you that severity of the anemia. So it's important to remember that if there's a quick drop in this hemoglobin, a very fast change over a very short period of time, the person's going to have very drastic symptoms because they're not able to compensate quickly for that loss. However, if you have a very slow drop in hemoglobin over a very long period of time, the patient may have minimal to no symptoms because their body is able to compensate. So think of, for example, a person who has a congenital abnormality of hemoglobin. So they have a defect, they were born with it, they've been dealing with it their whole entire life. They generally tolerate this anemia much better than someone else who had a sudden blood loss and is not used to that level. Laboratory diagnosis of anemias. So there are several tests that you will use to help differentiate the different types of anemias. You will almost always start with a CBC to give you the diagnosis. So that has your red blood cells, your hemoglobin, or your hematocrit to secure the diagnosis, as well as your red blood cell indices to help point you to the next steps. You also will likely receive a reticulocyte count, or should order a reticulocyte count, and for that you'll be looking for production versus destruction issues of the blood. A peripheral smear is helpful in giving you a qualitative analysis of the blood. And then there are some other tests that you would possibly order depending on your other results on your CBC, reticulocyte count, or peripheral smear, and these are listed below. So the iron studies, which are the ferritin, iron, total iron binding capacity, and the iron saturation. Another option would be your B12 and folate. Also, if you're worried about hemolysis, then you will order a bilirubin, LDH, and haptoglobin. The bilirubin is released from lysed blood cells, specifically red blood cells. The LDH, or lactate dehydrogenase, is released when all cells lyse, but is also seen when red cells lyse. And then the haptoglobin. The haptoglobin is a protein in the blood that binds free hemoglobin. So if there's cells that are being lysed, hemoglobin is released into the blood. And as the hemoglobin is released in the blood, the haptoglobin starts binding it and starts using up the haptoglobin. So you'll see a drop in haptoglobin when there's hemolysis occurring. A urinalysis will also be done to look for hemoglobinuria if there's suspicion for hemolysis. And then stool for occult blood is looking for bleeding into the GI tract. And about 3 to 6 stool samples are usually needed over a 2 to 3 week period because bleeding can be very intermittent with colon cancer. Now let's use all of the information we just talked about to do a flowchart representation of how you work up anemia. So if you have a patient with the signs and symptoms of anemia, the first thing you should do is get a CBC. If your CBC is negative for anemia, then you don't have anemia and you need to consider other options. If you have a positive anemia on your CBC, so either reduced red cells, reduced hemoglobin, or hematocrit, or all of those, then the next thing you should do is look at the MCV, which is still on the CBC itself, and you should also consider ordering a reticulocyte index. Based on the results of your MCV, you will either have a normocytic anemia, a microcytic anemia, or a macrocytic anemia. Let's start with the microcytic anemia. So for the microcytic anemia, once you've established that, your next step is to order the iron studies. So that is the ferritin, the serum iron, the total iron binding capacity, and the percent saturation of the iron. Once you get those results, you'll be able to differentiate between iron deficiency anemia, anemia of chronic disease, thalassemia, or sideroblastic anemia. And we'll discuss how you differentiate each of those later on in the lecture. If you happen to have a macrocytic anemia, the next step would be to order a peripheral smear. And the reason you order a peripheral smear is you want to look at the neutrophils. So on your peripheral smear, if you have the hypersegmented neutrophils, or PMNs, so that means that there's 5 or plus lobes of your neutrophils, hypersegmented, 5 or more. If you have those, then you have a megaloblastic anemia. And that means that the next thing you need to do is look at your B12 and folate testing. If you do not have hypersegmented polymorphonuclear cells, then that means that this is a non-megaloblastic anemia. So you need to look at other things, such as the liver, other metabolic issues, alcohol use, or medications as potential causes. And then if you have a normocytic anemia, you should be thinking one of two things. It's either going to be hemolysis or it's going to be blood loss. So what you want to do is do your hemolysis testing, so your LDH, your haptoglobin, and your bilirubin to look to see if there is hemolysis. If you have positive hemolysis, meaning that you have an elevated LDH, an elevated bilirubin, and a decreased haptoglobin, then the next thing to do is to get a peripheral smear, and that will give you your diagnosis. If you had a negative hemolysis panel, then you need to find the source of bleeding. So that means that you're having blood loss, and then you need to obviously treat that and give a transfusion. However, don't forget the but, if it is the normocytic and you have a low reticulocyte index, which you should have gotten up here, this is actually a production issue. So what does that mean? So if you have a normocytic anemia and your reticulocyte index is low, that means that you're not producing your reticulocytes, meaning that there's some sort of issue with the bone marrow. Meaning you should be thinking a possible malignancy. This also could be end-stage renal disease, which affects the bone marrow and production of red cells. But more than likely, you should be considering that there's a possible marrow issue. So now that we've discussed the workup from anemia, let's discuss the different types. You can see them all listed here for you, and these are the ones we'll be going through during this lecture. First, we're going to discuss the microcytic anemias. So again, the iron deficiency, anemia of chronic disease, thalassemia, and sideroblastic anemias. Iron deficiency anemias. Iron deficiency anemia, again, remember this is the most common reason to have a microcytic hypochromic anemia, as we discussed earlier. There are several different reasons you could see iron deficiency anemia. If there's a chronic blood loss, so again, not acute but chronic, so the big ones being GI bleeding, chronic use of aspirin, menstrual bleeding or uterine bleeding, or repeated donations of blood. Could also see iron deficiency anemia from issues of malabsorption. So this could be things like celiac disease or inflammatory bowel diseases, dietary deficiency or inadequate intake of iron. Pregnancy and lactation can also have a very high iron demand on the body and can cause iron deficiency anemia. Iron deficiency anemia can also be associated with zinc deficiencies, and you can also have chronic hemoglobinuria where there's blood loss through the urine that can cause iron deficiency. Signs and symptoms of iron deficiency anemia. Symptoms will include things such as fatigue, irritability, tachycardia, palpitations, tachypnea, pica, which is craving or eating non-food items such as ice chips, soil, cornstarch. I even had one patient that was eating laundry detergent flakes due to iron deficiency anemia and pica. Dysphagia, which is due to something called Plummer-Vinson syndrome, where esophageal webs form related to the iron deficiency. This is commonly in women. Pylore, atrophic glossitis, cholonychia, and angular cheilitis. The laboratory diagnosis of iron deficiency anemia. Again, remember the first thing you're going to do is your CBC, and this is going to demonstrate a microcytic hypochromic anemia. Also on your CBC, you'll see a high RDW because of the difference between the very small red cells due to the anemia compared to the normal cells and possibly any reticulocytes that might be in the circulation. So you will see that RDW elevate. Peripheral smear again will show that microcytic hyperchromic anemia. You also will see a lower reticulocyte count. There will be some present, but it won't be high. And remember that reticulocyte count indicates that this is a production issue or a hypoproliferative issue. Your serum iron will be low because you're deficient in iron. You can see the normal range is listed there for you. Typically it's going to be that 150, 175 depending on the laboratory. The total iron binding capacity, which is the spaces left to bring in iron, is going to go up because you're deficient in iron. You're going to have more binding sites available for the iron that should be there but is not. And a normal range for that is going to be about 250 to about 460, 450 depending on your laboratory. You can use the results of your serum iron and your total iron binding capacity to calculate a percent saturation. I'll write it down here for you. So you're going to have your serum iron, and that's going to be divided by the total iron binding capacity. And then all of this will be multiplied by 100 to give you your percent saturation of iron. And the normal range for this will be about 20 to 50% saturation. So that's a helpful value to have to give you an idea of how well the treatment of the iron deficiency is going. And then the last value is the serum ferritin. For the ferritin, this is the stored iron, so how much iron is stored in the bone marrow. The normal range for men is going to be about 16 to 300. So as you can see, a very, very big range. And the normal range for women is going to be about 12 to 150, 160. So again, a very, very large range. And typically, if you have a level under 12, that is highly reliable indicator of iron deficiency. So if you're seeing that, you should definitely be thinking that there is an issue with iron deficiency. It's also important to remember with the ferritin that the ferritin is considered an acute phase reactant, meaning it's a protein that increases by at least 25% when it's in the presence of any inflammation. So some other examples that you've learned about acute phase reactants would be things like CRP or ESR. So ferritin behaves the same as those types of proteins. So you can have a falsely elevated ferritin if there's other inflammatory issues or infections going on. So febrile illnesses or cancers, liver disease, any other inflammatory diseases could cause you to have an elevation in the ferritin. Please also remember that a normal ferritin does not necessarily rule out iron deficiency because of that. There have also been some recent cases showing iron deficiency without anemia, meaning that the patient has iron deficiency or low serum iron, an elevated TIBC, a low ferritin, and a low iron saturation, but they don't have anemia, meaning that they have a normal hemoglobin, hematocrit, and red cell count. When you have this, it's especially more common in women, and if it's not treated, it will eventually progress to anemia. So basically, the patient's body is doing a great job compensating at this time, and it hasn't reached that point of anemia. There can be symptoms with this, and they're very similar to the symptoms that you would see iron deficiency anemia. And if the patient is symptomatic, they should be treated, and it would be the same treatment as iron deficiency anemia. Many texts and board exams have not caught up with this iron deficiency without anemia. It's still seen mostly in research. I would say a lot of primary care providers are not familiar with this concept, and even some hematologists may not necessarily think that iron deficiency without anemia should be treated. But the most recent research does show that the symptoms will improve if you treat the patient as though they are iron deficient, because they are iron deficient. So even though they're not anemic, they still do require treatment. There's a nice article on this that was in the British Medical Journal recently, and I'm going to write that address for you here. So it's www.bmj.com/content/326/7399/1124.short. And this is a nice article on patients that had iron deficiency but were not anemic, and once they were treated, they had symptoms that resolved. So I definitely encourage you to take a look at that article if you get a chance. Treatment of iron deficiency anemia. The most important thing you can do for the treatment of iron deficiency anemia is identify the cause and treat that. While you're doing that, you also should encourage an increase in iron-rich foods. So some examples: meat, fish, eggs, dark leafy greens, beans, especially lentils, pumpkin seeds, dark chocolate are all great sources of iron. You also should be giving some sort of supplementation, and supplementation should start with oral iron therapy first. And this involves ferrous sulfate at 325 milligrams orally 3 times a day. If you give the 325 3 times a day, that provides about 180 milligrams of iron in the day. And of that, about 10 milligrams of that is absorbed. So that is the preferred therapy. The oral supplements should be taken with vitamin C to increase their absorption. And also, some newer literature also recommends considering taking it also with vitamin B12. There should be no other foods for at least 1 hour after the iron is taken, or 2 hours before the supplement is taken, to try and prevent interference of the absorption or competing absorption. Other things that could interfere with iron absorption, things like tannins. So these would be like things in red wine, or tannins are also in coffee and teas. If the patient's taking reflux medications, both over the counter or prescription, there can be some interference with the absorption of iron. You can also encourage patients to make sure they're cooking with a iron skillet, and that helps increase some of the intake of iron, to make sure that they're getting sufficient stores built up. If you treat a patient with oral medication and they fail treatment, so they're refractory to the oral iron, or they have some sort of intolerance to the oral iron, the biggest one being constipation, which is the most common side effect of oral iron, and you can treat that by giving stool softeners at the same time with the iron therapy. Or maybe they have GI disease where they aren't absorbing properly, then you should be considering parenteral iron. And previously, parenteral irons were iron dextran, and there was a lot of problems with very severe anaphylactic reactions to this medication, so it is not commonly used anymore. There are some newer medications, one of them being polyglucose sorbitol carboxymethyl ether, which is one of the ones that's used now, much safer for patients does not have that anaphylactic reaction that was seen with the iron dextran. And typically you will know if the patient is responding to the parenteral irons, the IV irons, because they will have a reticulocyte count that increases in about 5 days after treatment. So that tells you that that patient has a healthy bone marrow because they're able to kick out reticulocyte production again. If you're having adequate treatment with iron therapy, you'll see the hematocrit will rise about 1 point with each week of the oral therapy. So for example, if the patient has a hematocrit of 26 and you want to get them to that 36 to 40 range where they should be, it's going to take about 10 to 12 weeks of ferrous sulfate 325 3 times a day to get you to that point. If you don't get to that point, then you need to think that there's some sort of issue with the iron absorption, or perhaps that iron deficiency is not the diagnosis and there's some other problem going on. Now let's discuss some reasons for failure of oral iron treatment. As we discussed on the last slide, this could be due to an incorrect diagnosis. So things such as thalassemia or anemia of chronic disease could be possibilities. There could also be the presence of coexisting disease, specifically another anemia. So maybe you've already corrected the iron deficiency, but there may be another anemia present. Some other reasons, obviously, for failure of treatment could be patient noncompliance. And one of the big reasons for this is because of the GI side effects of taking oral iron, specifically upset GI issues or specifically constipation. So again, making sure that you are making the patient aware of ways they can treat their constipation. Often some people will prescribe stool softeners along with the iron to prevent this from the beginning. Malabsorption is definitely a concern with failure of oral iron treatment, and this can be because maybe there's enteric coated iron, so you may need to have the patient switch to a different supplement or maybe a liquid form. Antacids or other GERD medications can interfere with the absorption, and then coffee, tea, red wine intake can also disturb the absorption of iron. And don't forget about other GI diseases, specifically celiac and inflammatory bowel disease. And then, of course, another reason for failed oral treatment is maybe there is some blood loss, and the blood loss and the amount of iron lost in that blood loss is still greater than the amount ingested. So they just may need continued treatment, whether it be orally or parenterally. Blood transfusions for anemias. Occasionally, patients with anemias will require a transfusion to correct their anemia. This is less likely with iron deficiency anemia and more likely with other acute anemias. So these would be examples: a hemodynamically unstable patient that has some bleeding or maybe has some other end organ issues could require a transfusion. If a patient is stable but is in ICU and they're less than 7, most protocols will be to transfuse them. And sometimes that number will be 8 depending on the floor they're at and whether or not they have symptoms. And all patients should be assessed clinically for the need for a transfusion. In general, for transfusions, and we'll discuss this in another lecture, but if you give 1 unit of packed red blood cells, that is approximately 200 milliliters of red blood cells, and that's about 200 milligrams of iron. And that'll be important to remember later when we talk about some of the other anemias, because some people will need that iron, but other people will not need that iron if they have to have recurrent transfusions. Also remember that if you're giving 1 unit, that'll raise a patient's hematocrit by about 3%, and their hemoglobin will go up by about 1 gram per deciliter for each unit that you give. So for iron deficiency anemia, when do you refer? Often, iron deficiency anemia can be managed by a primary care provider, but in some cases it does require a referral to hematology. Anytime your diagnosis is not straightforward or the patient is not responding to oral treatment within a reasonable time, you should be considering referring to hematology. Anemia of chronic disease. Anemia of chronic disease is typically a microcytic anemia. There are occasions where you can see a normocytic anemia with this disorder. There are three types of anemia of chronic disease: anemia of inflammation, anemia of organ failure, and anemia of the elderly. In anemia of inflammation, there is low-level chronic inflammation that is leading to the anemic state. This is typically related to issues such as chronic infections, autoimmune disorders such as RA or systemic lupus, or a malignancy. In anemia of inflammation, you will see elevation of hepcidin, and hepcidin is a protein that is responsible for the regulation of the entry of iron into the circulation. For anemia of organ failure, this is usually related to either organ failure of the kidneys or the liver, and occasionally seen in endocrine organ failure. In these organ failures, the organs are no longer able to release a substantial amount of erythropoietin, and this decreases red blood cell production. Anemia of the elderly, there is not an organ failure, but there is still decreased production of erythropoietin, causing an anemia due to red cell production decreases. The signs and symptoms of anemia of chronic disease are the same as iron deficiency, plus the added features of whichever underlying disease is causing the inflammation. Let's first discuss anemia of inflammation. Anemia of inflammation involves a decreased availability of iron for hemoglobin synthesis. What ends up happening is there is inflammation which causes the upregulation of hepcidin, and this is due to inflammatory markers or mediators. So what ends up happening is the upregulation of hepcidin causes sequestration of the iron in macrophages. So the iron is pulled out of circulation and hidden from the body. And this is actually a defense mechanism. The body is trying to hide the iron from potential invaders. So if, for example, there was an infection, it's trying to keep that iron away from the bacteria, because bacteria depend on that iron to continue to multiply. So the hepcidin is upregulated to try and hide that iron, and this results in a negative regulation of iron transport due to the upregulation. So instead of it going into circulation, it's actually decreased in the serum and hidden from the rest of the body. For the diagnosis of anemia of inflammation, the CBC will show a low hemoglobin, often a normal hematocrit, and the MCV could be normal or low. It'll depend on the severity. Also, you will see low serum iron because the iron's being sequestered. You'll see a low TIBC because there is still binding sites available for iron, and you'll see either a normal or a high ferritin. And the reason for this is the ferritin is an acute phase reactant, and even though there's iron deficit, the ferritin can be elevated if there is very severe inflammation because it is an acute phase reactant. Anemia of organ failure. Again, this is due to decreased production of erythropoietin. So the organ is failing, and since it is responsible for the production of erythropoietin, there is not as much erythropoietin being produced, which leads to low production of red blood cells. For the diagnosis, there is often, again, a low hemoglobin, normal hematocrit, except for in kidney failure where you will see a low hematocrit, and then the MCV can be normal or low. For this, all of the iron levels will remain normal. For the treatment of anemia of chronic disease, the most important thing to do is treat the underlying cause. If there is also a secondary iron deficiency, such as in patients who have anemia of the elderly, that may also need to be treated. In severe cases, patients can be put onto erythropoietin or red blood cell transfusions to correct this type of anemia. Next, we'll discuss thalassemias. When discussing thalassemias, it's important to first discuss hemoglobin. Hemoglobin is made up of a heme and globin unit, and the heme portion contains an iron with 4 protoporphyrins. When you look at the molecule of hemoglobin, as in the picture here, you'll see that it has 4 chains, and in this case, there have 2 alpha chains and 2 beta chains. And every hemoglobin molecule will have 4 chains that make up the hemoglobin molecule, and the different chains will decide the type of hemoglobin that it is. The normal hemoglobins that you'll find in most people are listed here, and the most predominant one is your hemoglobin A1. This makes up about 97 to 99% of the hemoglobin in adults, and this is considered an A2 beta 2, which means 2 alphas and 2 betas, as in the picture here. The hemoglobin A2 makes up 1 to 3% of adults' hemoglobin, and this has an alpha 2 and a delta 2. The other hemoglobin that you may find in some adults is the hemoglobin F, or fetal hemoglobin. This makes up less than 1% of the hemoglobin in their blood, and this is an alpha 2 and a gamma 2. Fetal hemoglobin is predominant in a fetus and when an infant's first born, and over a 3 to 6 month period, the blood changes over to the typical A1 and A2 hemoglobins. Thalassemias. Thalassemias are a hereditary disorder which involves a reduced synthesis of globulin chains. And this is important to remember because thalassemia is a globulin issue. Other anemias like iron deficiency anemia and anemia of chronic disease are problems with heme. So it's important to make sure you know that this is globulin. And the decrease in the globulin chains leads to decreased hemoglobin synthesis. Thalassemias are hypochromic microcytic anemias, and there's 2 types we'll discuss, alpha and beta thalassemias. So first we'll talk about alpha thalassemias. Alpha thalassemias involve a reduction in the alpha chain production, and this is often due to a gene deletion. In these issues, you have a defect in alpha chains, so you have extra beta chains. And you can have several different variations of alpha thalassemia, and those are listed in the chart below for you here. So if you have an alpha globulin gene and you have 4 of them, which is how many you would normally have, you have all your chains, so this patient would be characterized as normal. They will have a normal hematocrit and a normal MCV. If there is 1 gene deleted, so they have 3 normal alpha genes with 1 gene deletion, these patients are considered a carrier. So they're a silent carrier. They still have normal hematocrit and normal MCV. If there are 2 chains deleted, 2 normal chains present, these patients are characterized as having thalassemia minor, and they will have a decreased hematocrit and a decreased MCV. And it's mild to moderately decreased. If there are 3 deleted alpha chains, so only 1 present, these patients have hemoglobin H disease, have a very low hematocrit, and again, moderately low to low MCV. If all the alpha chains are gone, so 4 gene deletions, no alpha chains at all, these patients will have what is called Bart's hemoglobin, which results in hydrops fetalis, and this is incompatible with life, so this results in a stillbirth. So let's look at the alpha thalassemias a little more closely. For thalassemia minor, or 2 gene deletions, there will be a mild microcytic anemia, and these patients have a very normal life expectancy and are clinically normal. If you have a patient who has hemoglobin H disease or 3 alpha chain deletions, the beta chains cannot pair with anything else except for an alpha or itself, a beta. So what ends up happening, because there are significant decreases in alpha, is there's beta tetramers, so 4 betas, that start chaining together. And these are called hemoglobin H. So the beta tetramers are not able to carry oxygen well and are basically useless, and they will cause hemolysis to occur. So in the case of hemoglobin H disease, although it will be microcytic, you will also have a hemolytic anemia. Because of the hemolysis, you will also have the splenomegaly because the spleen is trying to clean out all those bad, broken up red blood cells. And then you'll have the typical pallor that occurs with anemia. In the next version, hemoglobin Bart's, there are 4 gene deletions. All alpha chains are deleted. And with these, you'll have the gamma tetramers also forming. And this is called hemoglobin Bart's. And this will cause a stillborn because they are not able to carry any oxygen. To make the diagnosis of alpha thalassemias, if the patient has alpha thalassemia minor, this is a diagnosis of exclusion. So you have to exclude all other thalassemias and all other causes to come to this diagnosis. Again, the laboratory data, hypochromic microcytic anemia, and you also will see on occasion on the peripheral smear those target cells. They'll have normal reticulocytes and normal iron. They will have a normal, this is important to remember, normal hemoglobin electrophoresis for alpha thalassemia minor. There are some genetic tests that can look for the alpha gene deletion, and this would be important for family planning purposes. For the hemoglobin H disease, they will have a very abnormal peripheral smear with microcytosis and hyperchromia, and they will also have target cells. And then again, you may also see some hemolysis. They will have an elevated reticulocyte count because the blood is trying to kick in some immature red cells to compensate. And a hemoglobin electrophoresis will show a fast migrating hemoglobin H. And this is the best way to diagnose hemoglobin H disease. Now let's discuss beta thalassemia. This is especially seen in people who are from Mediterranean origin or have family that is of Mediterranean origin. And beta thalassemia is a point mutation, so it can cause either a gene deletion or absence of beta chain, or you can have a reduction in the beta chain. If you have an absence, it'll be noted as beta 0, and if there's a reduction, then it'll be noted as beta plus. Because there are beta chains that are absent, you'll have an increase in your hemoglobin A2 or your hemoglobin F, which is your fetal hemoglobin. So you're replacing them with gamma and delta chains. When you have a reduction in the beta chain, there is also more unstable hemoglobins, so you also will see hemolysis with beta thalassemia. Beta thalassemia table is below, and you can see the typical appearance. So if you have a normal patient, they have 2 betas, which is what they should have, and they will have very normal hemoglobin. So they have their A2B2, makes up the most of their hemoglobin, and then they have a very small amount of the hemoglobin A2 and the hemoglobin F. In thalassemia minor, they are missing one of their beta chains. They still have another beta chain available, so they still can make some hemoglobin A, but it's a reduced amount, and you will see a small increase in the hemoglobin A2 and the hemoglobin F. There is a hemoglobin thalassemia intermedia, and what happens is they have some reduction in the B chain synthesis, and there's varying degrees of reduction, so they could have complete reduction or they could have partial reduction, but in general they are able to make some hemoglobin A, but not in all cases. So they could have mild to moderate, possibly severe disease, depending on how much of a reduction they have. And you can see some other A2 and hemoglobin F being produced. And thalassemia major, which is the most severe, they are missing both of the beta globulin chains, and therefore they can make no hemoglobin A, because they have no betas available, and they make a pretty large amount of hemoglobin F and even a small amount of the hemoglobin A2. So the majority of their hemoglobin in this case is going to be fetal hemoglobin. For thalassemia intermedia, again, this is a milder form. They tend to have some hemolysis occurring, so there is some hemolytic anemia, and they will only require transfusions, and this is the important part to remember, when there's times of stress. Otherwise, they're pretty normal. For thalassemia minor, they will have a clinically insignificant microcytic anemia. So again, very minor, and most do not require treatment. For thalassemia major, these patients are missing both beta chains. At birth, these patients will be normal because they haven't switched over from the fetal hemoglobin yet. At about 3 to 6 months, when the hemoglobin F starts switching over to the hemoglobin A, so the alpha chain beta and beta chain hemoglobins, this is when they start to run into problems. For these patients, they will have failure to thrive, so they don't grow properly. They can have deformities of the bones, especially in the facial areas, especially the forehead, possibly some fractures. The spleen will become enlarged because there is hemolysis occurring, and also because there's significant hemolysis, you will see some jaundice because of the bilirubin that's being released from the broken red blood cells. And the most important thing to remember for this is that these patients are dependent on transfusions. They have frequent transfusions. So how do you diagnose the different thalassemias for beta thalassemia? Beta thalassemia minor, again, remember, modest to mild anemia, microcytic, hypochromic. Those target cells will also be on the peripheral smear, but the most important way to diagnose it is to do this hemoglobin electrophoresis. And for this, you will see, although they can still make some of the hemoglobin A, which is the alpha and beta chain hemoglobin, they still have to make some of the A2 and the F hemoglobin to be able to survive. So you will see those show up on the electrophoresis. Typically, they should not be present or present in very low amounts. For beta thalassemia major, these patients have very severe anemia. They are having hemolysis, so they also have hypochromia, microcytic cells. Lots of immature red cells, or the nucleated red cells, are coming through as well. And for this, again, hemoglobin electrophoresis is the most important way to diagnose this. They will have no hemoglobin A, a variable amount of A2, and they will have a lot and predominantly hemoglobin F, or the fetal hemoglobin, present. Treatment of thalassemias. These patients should be treated by a hematologist. If the patient has mild thalassemia, such as alpha thalassemia trait or beta thalassemia minor, really no treatment is required. Most of them do not need any treatment. If they have hemoglobin H disease, patients should be given folate supplements because if there's any hemolysis, this will deplete some of the folate. And they should also avoid oxidative drugs because this can precipitate more hemolysis. And examples of oxidative drugs include sulfonamides and quinolones. There's a bunch of others in this category, but those are the two big ones to avoid. If the patient has very severe thalassemia, they will be transfusion dependent, and they will require regularly scheduled transfusions. They also need the folate supplements due to the hemolysis. If there's a lot of hemolysis occurring, they will also have a spleen that's being overworked and have hypersplenism and require a splenectomy. If they're having lots of transfusions, there will be a buildup of iron, but since these patients do not have an anemia that is an iron problem, they need to be given iron chelating agents to make sure that they don't have iron overload. And an example of some of these agents are deferoxamine or deferoxirax. And these are easy to remember because you have this chain of defer in here on both of them. And if you think of it this way, divided in half, you have fer as in ferritin and D as in getting rid of, so it's getting rid of iron. And then also for some patients with very severe thalassemia, such as beta thalassemia major, they may eventually end up needing a bone marrow transplant to cure their disease. So now let's discuss some ways to remember the difference between the thalassemias. The first thing that is important to remember is this is a globin issue, not a heme issue. Make sure you remember that. For the thalassemias, it's helpful to divide them up into the problems with the alpha gene versus problems with the beta genes. So let's write up some examples of these guys. Okay, so if we have one gene on the alpha, that's a problem. The patient will not have any symptoms. If we have two genes that are a problem for the alpha, they'll have mild symptoms. If there's 3 genes that are now missing, then they will have severe symptoms. And if they're missing all 4 genes, this will result in the hydrops fatalis. For the beta gene, instead of 4 genes, there's only 2 genes for the beta. So we can take out these top portions right here. And if we have 1 beta gene missing, they'll have mild symptoms. If both are missing, both genes are for beta are missing, they have severe symptoms. Now don't forget, with the beta genes, we can also have issues with production or issues with their functioning, even though the gene's missing. So if they have reduced function, then you can have the intermedia. And those symptoms can vary depending on the degree of function issue. So for these, first step, if you have a microcytic anemia, is you're going to order iron studies. And those iron studies are all normal. So that should prompt you to be thinking about thalassemia. So next thing you would do is order a hemoglobin electrophoresis. Remember for these that normally you have your hemoglobin A or A1, and that is an alpha 2 beta 2, 2 alpha chains and 2 beta chains. So that should be the majority of your hemoglobin in a normal patient. You also can have the other hemoglobins present, hemoglobin A2, which is an alpha 2 and a delta 2. And you can have your fetal hemoglobin, hemoglobin F, which is alpha 2, gamma 2. So if you have a problem with the beta chains, meaning beta thalassemia, then these are going to be what you see on your electrophoresis. So if you have hemoglobin A2 and hemoglobin F in there in increased amounts, very high amounts, that gives you your diagnosis of beta thalassemia. Now if you do your electrophoresis and you don't have these results, then you need to look at alpha chains. So we'll come over here to look at some of those alpha chains. There's going to be a couple different ones. So if you have a carrier, so alpha thal carrier, there's going to be no symptoms and they would likely never be tested. If you have alpha thalassemia trait, they will have a normal hemoglobin electrophoresis. So this is actually a diagnosis of exclusion. You'd run all the testing for beta thalassemia and the other alpha thalassemias and they wouldn't show up, and so that's how you would diagnose that. If you had hemoglobin H disease, remember that there's not enough alpha chains, so the beta chains start forming the beta tetrameres. And those beta tetrameres are hemoglobin H, and they migrate fast. And that would give you your diagnosis. Finally, you have alpha Thal major, which is also the hemoglobin Barts, and that makes the Barts hemoglobin, which are gamma tetramers. And remember that this would result in hydrops fetalis. So that would also give your diagnosis. They have found recently that with infants that are diagnosed in utero with alpha thalassemia major have been treated, so they can do transplants for those patients. And if they're treated early, they do have some chance of survival, and that's something that's been very new. But traditionally and on the boards, if the patient has these Barts hemoglobins or thalassemia major, alpha thalassemia major, it's equivalent with hydrops fetalis. Sideroblastic anemia. Sideroblastic anemia is an issue with decreased synthesis of heme, and this will cause accumulation of iron within the cell, specifically in the mitochondria. Most common causes for sideroblastic anemia is myelodysplastic syndrome, followed closely by toxins, specifically lead. This sideroblastic anemia will present the same as the other anemias, and sideroblastic anemia has a microcytic hypochromic appearance on the CBC and the peripheral smear. If you run iron testing on sideroblastic anemia, you will see an increase in serum iron. As well, a bone marrow biopsy will show ringed sideroblasts, which is where the name comes from. So you'll see on here, in this example of the bone marrow biopsy, some of the different cells that have these rings that form around it, and these are the sideroblasts. As well, if it is a lead poisoning, you will also see basophilic stippling on the peripheral smear. For these patients, they often will need some support with transfusions, but ultimately they should be treated by a hematologist. Now let's talk about macrocytic anemias. These will include vitamin B12 deficiency and folate deficiency. First, we'll talk about B12 deficiency anemia, also called methylcobalamin anemia. There's a common misconception that B12 anemia is only in vegetarians and is not in meat eaters, but it's important to remember that vitamin B12 is actually from a bacteria that is in the soil. This is found on specifically the roots of the vegetation of plants, and then it is eaten by animals and incorporated into their muscles. So whether that be a human eating the root vegetable or the roots of the plant, or a animal eating the plant to get the B12. What happens with meat eaters is they will then eat the animal and they will absorb the B12 from that muscle that's been stored there. It's important to keep in consideration that if an animal is not grass-fed and is instead on a factory farm and grain-fed, they will have little to no B12 in their muscles. So it is still possible for meat eaters to be B12 deficient. However, you will see B12 deficiency a lot more in people who do not eat animal products. B12 is bound to a protein produced by the gastric parietal cells, which is called intrinsic factor. Intrinsic factor allows the B12 to be properly absorbed in the ileum and then brings it to the circulation. B12 deficiency will cause a macrocytic anemia, as pictured below. You can see the macrocytosis in many of these cells here. They're all pretty large. And you also will see this hypersegmented polymorphonuclear cell, which we'll talk about in a little while. So to review some of the causes of B12 deficiency, there can be decreased intake of B12. This would be a plant-based diet that's lacking supplements with either B12 or allergy products. Allergy has a high amount of B12. You can also see B12 in infants that are breastfed exclusively. Another reason you could see B12 deficiency is there is a decrease in the production of the intrinsic factor. This is known mostly as pernicious anemia and is autoimmune. And you can also see this after a gastrectomy because the intrinsic factor comes from the stomach's parietal cells, and if there are no parietal cells, there is no intrinsic factor. H. pylori infections can interfere with the B12 absorption. If there's other competition for B12 in the gut, so things like blind loop, or if there's a tapeworm, there can be B12 deficiency due to pancreatic insufficiency because there's not good absorption in the stomach and in the ileum. There can be decreased ileal absorption as well due to resection of the ileum or Crohn's disease. And there's also a couple different deficiencies, specifically transcobalamin 2 deficiency, which can cause problems with B12 and its absorption. Signs and symptoms of B12 deficiency. Often patients do not know that they are B12 deficient and may be asymptomatic, and you may find a B12 deficiency on a routine CBC. For patients that are symptomatic, they tend to have the general symptoms that you would see with anemia, fatigue, irritability, tachycardia, tachypnea, dyspnea and exertion, as well as some other symptoms such as anorexia or weight loss, diarrhea or constipation. They could have some icterus. They may have the glossitis, which is again that smooth tongue due to the loss of the papillae. And then there's several neurologic symptoms, and these are the most important ones to keep in consideration, including decrease of vibratory sense and positional sense, paresthesias, especially in the peripheral nerves, trouble with balance, and then if they progress far enough, they could have psychosis or dementia. Diagnosis of B12 deficiency. First, you'll start with a CBC, and on CBC, you will see macrocytic red blood cells, typically in the range of 110 to 140. For B12 deficiency, the peripheral smear will also demonstrate megaloblastic white blood cells, specifically neutrophils, and these are the ones that have 5 or more lobes. These also may be called hypersegmented polymorphonuclear cells. You may also see schistocytes if the red blood cells are lysed, and this happens because of macrocytosis. The red blood cells become so large that eventually they burst. The hallmark for diagnosis of B12 deficiency is a low serum vitamin B12. With these, patients are usually not symptomatic until they're below 100, and if you have an equivocal range or a borderline range and you're not sure of the diagnosis, you should order a serum methylmalonic acid, also written as an MMA. If this is elevated, then it confirms the diagnosis of B12 deficiency. And this is important because it can help you rule out other causes of low vitamin B12, such as renal insufficiency. You can also perform a bone marrow biopsy for vitamin B12 deficiency, and in this you'll see megaloblastic changes. So let's talk a little bit about pernicious anemia. So as we mentioned before, you can have pernicious anemia, which is a type of B12 deficiency. And with this, pernicious anemia is an issue with the intrinsic factor. And remember, the intrinsic factor is important for B12 absorption. It must be present in order to absorb the B12. And if the patient lacks the intrinsic factor, it could be due to atrophy or removal of the stomach, but usually with pernicious anemia, it's going to be antibodies against intrinsic factor and the parietal cells of the stomach. For this, there is a test that you can do to test for pernicious anemia that's called the Schilling's test. And I have a little bit of information written out for you here to please make sure you look through regarding how the test works. But basically, the patient is given a drink that has radioactive B12, and they go to see how much the patient absorbs. And then the test is repeated, but this time they're also given intrinsic factor along with that. And they look to see if there's a difference between the amount of B12 absorbed when there's no intrinsic factor versus intrinsic factor. Typically, the Schilling's test is no longer used in practice. It's still used in a couple places, but it's not common. And it's important to still know because it is still likely to appear on a board exam, so do make sure that you're familiar with that test. Instead, you'll see on the next slide that we tend to use antibody testing now for pernicious anemia. So this is the information on the pernicious anemia testing, intrinsic factor antibody tests. And there are 2 different types of intrinsic antibodies, type 1 and type 2, which are both very specific for pernicious anemia. and those are the most common tests used now. There's also an antibody test for antibodies against the parietal cells of the stomach, and this could be pernicious anemia, but it's not specific to pernicious anemia. Treatment of vitamin B12 deficiency. To treat vitamin B12 deficiency, patients should start with a parenteral B12, meaning that it's given IM and not given orally. The IM version of vitamin B12 is cyanocobalamin, and 100 micrograms of this is given every week for 1 week. Then 100 micrograms are given IM every week for the next month or 4 weeks. Then after that period is done, that 5-week period, the patient will either be started on continued IM cyanocobalamin, or they'll start an oral B12, and this depends on their diagnosis. If they have a straight B12 deficiency, they will be able to continue oral B12 because their intrinsic factor and parietal cells are still functioning properly. If the patient has a pernicious anemia, they will not be able to take oral B12 because they do not have functioning intrinsic factor or functioning parietal cells, and so every month they will need an injection of the cyanocobalamin 100 micrograms. This will be the answer that you'll use for all exam questions. However, technically, oral B12 can be effective even in pernicious anemia once the deficiency is corrected with parenteral B12. This is because there is some passive diffusion, about 1% of B12 into the intestines. However, parenteral B12 is still the recommended treatment. So if it's an exam question or a board question, make sure for pernicious anemia you select parenteral B12. Response to B12 deficiency treatment. Overall, most patients respond very well to treatment for B12 deficiency, noting a feeling of well-being and alertness pretty quickly after treatment. There is a small possibility that hypokalemia could develop if they have a very severe anemia, so that should be something that you should monitor for. If the patient had some of the neurologic abnormalities that we discussed, the paresthesias or the problems with vibratory or positional sense or the problems with balance, it may take up to 6 months for these to completely reverse. Typically for these patients, the CBC will become normal in about 2 months. Folate deficiency. Folate is present in vegetables and fruit, especially in leafy greens and citrus. And this is a vitamin, also known as vitamin B9, that is absorbed in the jejunum. It circulates in the blood as 5-methyl-THF, or tetrahydrofolate, and it is responsible for the synthesis of purines and pyrimidines. If you have a deficiency in folate, this is typically related to some sort of nutritional issue. The most important thing to remember for folate, as far as exam and board questions go, is that folate is responsible for neural tube defects, specifically when a mother is carrying a fetus, and it also has some implications in colon cancer. People have very small reserves of folate, so they do develop folate deficiencies very quickly. Folate can also cause some elevation in homocysteine, and so it's implicated in the increase in atherosclerosis, but also thrombosis. So there's a higher risk of clots with folate deficiency. Folate deficiency also should be distinguished from B12 deficiency in that it does not have any neurologic signs, while B12 does have neurologic signs. There are several etiologies of folate deficiency, the big ones being diet, alcoholism, trouble with absorption, increased requirements, and then loss of folate. And the most important ones to remember would be alcoholism, and alcohol abuse causes a decrease in folate metabolism. And then in pregnancy, you can also see increased requirements for folate because of the developing fetus, and patients who have hemolysis will also have folate deficiency because they have increased cell turnover and they lose folate due to that turnover. So if a patient has hemolysis, whether it be a hemolytic anemia of any sort, they should also be supplemented with folate. Laboratory diagnosis of folate deficiency. The CBC and peripheral smear will show macrocytosis in folate deficiency. Because it is also a megaloblastic anemia, you will see hypersegmented neutrophils. Ultimately, the diagnosis of folate deficiency will come down to folate testing, and you have two options, to do a serum folate or an RBC folate. This is somewhat of a controversial area. Some providers do believe that serum folate is sufficient. However, others do believe that RBC folate better reflects the stores of folate. So think of it similar to like a ferritin. This is because RBC folate is not affected by recent diet intake, while a serum folate measures the acute folate changes. So if you see a serum folate less than 12, you should consider the diagnosis of folate deficiency, and RBC folate less than 150 would be consistent with folate deficiency. If you order a serum folate first and it is borderline or equivocal, then consider ordering an RBC folate. It's also important to make sure that you order serum B12 levels, and this is because you could have a mixed anemia of both B12 deficiency and folate deficiency, and the folate deficiency could cover up some of those typical neurologic signs that you would see with B12. For the treatment of folate deficiency, a patient should be given 1 milligram of folic acid daily. It's also important to treat the underlying disorder if there is one that can be treated. Always make sure that you check for a B12 deficiency before starting treatment. If a B12 deficiency is not treated, then the neurologic symptoms can worsen and eventually become permanent. So when you're in doubt, always treat both B12 and folate together. The response to treatment will usually show reticulocytes within a couple days and a normal CBC within 2 months. It's also important to remember that the doses of folate will vary for pregnancy, and we'll be discussing that in the OBGYN course. Next, we'll discuss the normocytic anemias. These include hemolytic anemia, hereditary spherocytosis, paroxysmal nocturnal hemoglobinuria, glucose 6-phosphate dehydrogenase deficiency, autoimmune hemolytic anemia, aplastic anemia, and sickle cell disease. Hemolytic anemia. Hemolytic anemias involve a reduction in the survival of the red blood cell. Typically, you will have the bone marrow compensating for the decreased survival by sending out reticulocytes or immature red cells, and it will do this until it is not able to compensate anymore. Typically, hemolytic anemias are normocytic. However, you could have macrocytosis if you have reticulocytes or spherocytes in hemolytic anemia, and this will depend on the severity of the anemia. If you continue to have a falling hematocrit and the reticulocytes are stable and you do not have a source of bleeding, then hemolysis is most likely your diagnosis. In the cases of hemolytic anemia, these patients should be managed by a hematologist. Hemolytic anemias are classified as intrinsic or extrinsic. The intrinsic include things such as membrane defects, glycolytic defects, oxidation, vulnerability, and hemoglobinopathies. And intrinsic causes include immune causes, microangiopathic causes, infection, hypersplenism, and burns. We'll discuss these further in the following slides. The laboratory diagnosis of hemolytic anemias. First, we start with the CBC, and often, as we discussed before, these are normocytic anemias. Occasionally, you can see some increased reticulocytes and spherocytes, which could make it seem more macrocytic, but typically normocytic. The peripheral smear, as we mentioned, you might see reticulocytes, you might see spherocytes, you will likely see schistocytes or broken up red blood cells, and polychromia, meaning that these cells have multiple different variations of red. So they might be having a little bit of hypochromia, a little bit of hyperchromia, and all of that in between. You'll also see decreased serum haptoglobin. Remember that this is a plasma protein that binds hemoglobin. So as cells, red blood cells are being hemolyzed or broken up, they release hemoglobin, and the hemoglobin is bound by the haptoglobin. So as there's more hemolysis, the haptoglobin drops because it's binding hemoglobin. You'll also see serum lactate dehydrogenase because there's lysis of cells, and unconjugated bilirubin will also be increased due to the lysis of cells. Remember that if you're seeing unconjugated bilirubin, you also are likely to see jaundice. Hemoglobinuria and hemocistinuria will be seen on urinalysis due to the broken red blood cells, and you will have a direct Coombs test as well. And the direct Coombs test is the important one to remember for hemolytic anemias because it will tell you what the cause of the hemolytic anemia is. If the direct Coombs test is positive, then the hemolysis is due to some immune-mediated issue. And if it's negative, then there's an intrinsic cause. Hereditary spherocytosis. Hereditary spherocytosis is a type of chronic hemolytic anemia, and there is always a family history, and this is an autosomal dominant disorder, and this is due to an issue with the membrane proteins of the red blood cells, most commonly spectrin. And in these you will see anemia, and it will be variable severity. There will also be jaundice and gallstones, and this is related to the increase in bilirubin due to the breakdown of the red blood cells. The gallstones will be very early in these patients, so instead of seeing them in older patients, you will see them in teens or young adults. And you will also see splenomegaly, and this is due to the hemolysis as well. As the bad red blood cells are filtered through the system, the spleen filters them out, and the spleen is working very hard, and so the spleen enlarges. Hereditary spherocytosis, for the diagnosis, again, remember it's likely a normocytic anemia, and the anemia could be very mild because the bone marrow is compensating. You also will often see a folate deficiency because there is hemolysis, and it's not uncommon to see infection in severe cases of hereditary spherocytosis. The best thing you can look at to diagnose would be these spherocytes, which appear on the peripheral smear. And the two important tests for this portion would be the osmotic fragility test and the direct Coombs test. The osmotic fragility test is changing the osmotic pressure outside of the cell, and because this is a spherocyte, it's a very large cell. Think of a balloon that's been blown up very large. It's under a lot of tension, and so if you change the osmotic pressure, the cell will rupture very easily and give you a positive osmotic fragility test. Also, the direct Coombs test is important because the direct Coombs test will be negative, and that will tell you that this is an intrinsic issue, meaning an issue inside of the cell, and therefore it's not an autoimmune issue or a problem outside of the cell. So direct Coombs negative tells you it's intrinsic, meaning there's a problem inside the cell or a problem with the cell membrane, as is the case with hereditary spherocytosis. These patients will ultimately be treated by a hematologist, and treatment will include folic acid supplementation and likely splenectomy. Paroxysmal nocturnal hemoglobinuria, or PNH. PNH is a special situation because this is the only acquired intrinsic, so it's intrinsic, hemolytic anemia. All the rest are hereditary. This involves the red blood cells being lysed by the complement system. So these are specifically CD55 and CD59. Not only do these CD55 and CD59 attack the red blood cells, but they also attack white blood cells and platelets in some cases, and then could eventually lead to what is called aplastic anemia. The signs and symptoms of PNH include episodic hemoglobinuria, which is this red-brown color to the urine that's most common in the morning, and then also this nitric oxide levels that are altered due to the free hemoglobin. And those nitric oxide levels cause the majority of the major symptoms, such as esophageal spasms, erectile dysfunction, renal damage, and the most concerning symptom is the thrombosis, which has the most mortality for these patients, specifically mesenteric or hepatic thrombosis. The diagnosis of PNH is made based on finding an anemia, then finding elevated LDH, indicating that there's hemolysis, And then the ultimate diagnosis is done by both the Coombs test and flow cytometry. The direct Coombs test will test negative because this is an intrinsic cause of hemolysis. And the flow cytometry, which is the gold standard test, will show that there are CD5 and CD59 complements on the red blood cells and granulocytes. For the treatment of PNH, this should be done by a hematologist, and the hematologist will likely recommend an allogenic stem cell transplant for definitive treatments in patients who qualify. Another option is to use eculizumab, which is a monoclonal antibody that prevents the attachment of the CD59 and CD55 to the red blood cell. This is a medication that does increase quality of life, but it is not curative of PNH. The patients will need less blood transfusions with the medication, but there is no change in their risk for issues such as thrombotic events, and also this medication is very expensive. Glucose 6-phosphate dehydrogenase deficiency, also known as G6PD deficiency. This is a chronic hemolytic disorder that is X-linked recessive, meaning that you'll see it more in males, and it is a problem with the ability of the red blood cells to deal with oxidative stress. When there's oxidation present, the hemoglobin will denature. You'll form Heinz bodies, which are commonly found on the peripheral smear, and these Heinz bodies will result in damage to the red blood cell. Patients with G6PD deficiency will have episodic hemolysis, and these can be mostly due to oxidative drugs, the big ones being sulfonamides, nitrofurantoin, quinolones, isoniazid, chloroquine, and quinin. You can also see G6PD episodes with infections, and the one abnormal but commonly quoted on boards cause of G6PD is fava beans. Between these episodes, these patients are very healthy. The peripheral smear is helpful in suggesting G6PD and often shows both bite cells and Heinz bodies. The bite cells are caused by the spleen, where it is trying to remove the Heinz bodies from the red blood cells. So you can see some examples here of bite cells on the peripheral smear, and Heinz bodies, as we spoke about earlier in the lecture, are inclusions in the cell. Ultimately, the diagnosis for G6PD deficiency should be done by the enzyme assay for G6PD. If this assay is done at the time of hemolysis, it could be misleading because these abnormal cells have already been removed by the spleen. So the best thing to do is retest for the assay in 4 to 6 weeks after the drug or the infection or whatever was causing the oxidation has been removed or resolved, and you will see positive results for that assay. Treatment for the patients is to avoid all known oxidant drugs or oxidant stress, or be very careful of infections. Sickle cell disease. Sickle cell disease is a hemolytic anemia that is autosomal recessive, meaning it's a little bit more common in males. And sickle cell disease involves hemoglobin S. In hemoglobin S, the valine is substituted for the glutamic acid in the beta chain, causing the defect that will cause sickling in these patients. There are several different types of sickle cell disease, the most common being hemoglobin SS disease, hemoglobin SC disease, and hemoglobin SB thalassemia or S beta thalassemia. Hemoglobin SS disease has a homozygous patient, so they have 2 hemoglobin S's. You can also have sickle cell disease that are heterozygotes, meaning that they have a hemoglobin S and then a hemoglobin C. Or you can have hemoglobin S with beta thalassemia, so they have a hemoglobin S and they also have beta thalassemia. The biggest concern for these patients is vaso-occlusive disease, and the severity of these symptoms can vary greatly. There is a decreased lifespan depending on the type of sickle cell disease. Hemoglobin SS is the most common and the most severe and has a lifespan of approximately 42 to 45 years of age. Hemoglobin SC is a little less common and a little less severe, with a lifespan of 60 to 80 years old. And hemoglobin S beta thalassemia has mild symptoms, and they are believed to have normal lifespans. Typically, the symptoms of sickle cell disease begin around 3 to 6 months of age as the hemoglobin F starts to decline. Vaso-occlusive disease. In sickle cell, there is hyperviscosity and tissue hypoxia, which can cause occlusion of vessels. This is brought on by infections, hypoxia, or dehydration, and this can cause a variety of symptoms, but the most concerning are tissue death, fever, and severe pain. A couple examples of types of vaso-occlusive diseases that you'll see would be infarction of the spleen, or autosplenectomy, which means the infarction causes the spleen to necrose and die. You could have bone infarctions and very severe bone pain, aseptic necrosis of the femoral head, so this would require emergent surgery. Patients will often present with priapism and impotence. You can have also obstructions of the retinal vessels and also have eye changes related to vaso-occlusive disease, as well as ulcers in the legs. But the most concerning of all the symptoms is a stroke, which is due to the vaso-occlusion. Patients can also suffer from acute chest syndrome with sickle cell disease, and this presents with fever, very severe chest pain, tachypnea, cough. They can have low saturations for their oxygen. If it's around long enough, they could start to have pulmonary infiltrates. These infiltrates happen because there's sickling, and the sickling gets stuck in the lungs, and then they have infiltrate as a result of that. They can have both very chronic or subacute crises, and some of the complications can include pulmonary hypertension, corpus mole, or even death. And the treatment for this is emergent treatment, and it's very important to get antibiotics on board, be sure the patient is well hydrated and has lots of fluids, and it's very important to make sure they have pain medications for this. Diagnosis of sickle cell disease. We'll first start with a CBC, and typically the hematocrit will be about 20 to 30%, so a low hematocrit. It's also possible to see increases in the white blood cells and platelets as well because of the decreased hematocrit and other processes within sickle cell disease. The peripheral smear often is normocytic and normochromic, but is still demonstrating an anemia. You will often see reticulocytes, and the most common thing you'll see and most important to remember are these sickle cells, which are pathognomonic for sickle cell disease, as well as Howell-Jolly bodies. And if they have the hemoglobin S beta thalassemia, you will also see target cells. In sickle cell disease, the Coombs testing is negative as it is an intrinsic issue, and the hemoglobin electrophoresis will be the ultimate for definitive diagnosis, so make sure that you are getting that electrophoresis. There are many long-term sequelae of sickle cell disease, the first being growth retardation and delayed puberty, so failure to thrive. There is also bone abnormalities, widening of the medullary spaces, scarring due to infarcts, and most concerning would be avascular necrosis. Patients with sickle cell disease are at high risk for sepsis, and this is especially due to the marrow infarcts and also the asplenia, or lack of a spleen. They do have a higher risk for renal disease, and also because of the hemolysis, they're at high risk for gallstones. It's important in the treatment of sickle cell disease to be sure that the patient is referred to a comprehensive sickle cell center. The early diagnosis is really crucial for these patients. As far as prevention, these patients should avoid high altitudes, exposure to cold, and manual labor. And it's very important for them to have the pneumococcal vaccine, especially if they're at risk for asplenia. The standard treatment for sickle cell disease is hydroxyurea, which increases the amount of fetal hemoglobin and helps to decrease some of the sickling that can be seen in the disease. Some other treatments that might be needed for patients with sickle cell disease include splenectomy, cholecystectomy, treatments for their retinal vessels, IV hydration and IV pain medications when they have pain crisis is very crucial. These patients may also need red blood cells, transfusions if they have an aplastic or hemolytic crisis, and they may also qualify for bone marrow transplants in very severe cases, which may lead to cure. Sickle cell trait. Patients with sickle cell trait are heterozygous for hemoglobin S and usually have benign disease. Their red blood cells may sickle at very low oxygen tension when they are exerting themselves significantly, especially if they're at high altitudes. This is one of the reasons that the NCAA requires student athletes that are at risk to be tested for sickle cell trait. These patients do have a normal lifespan, and their RBCs also have a normal lifespan. They do have a slightly increased risk for blood clots, and usually there is no treatment needed unless they have some sickling, which is pretty rare. It is recommended that these patients have genetic counseling. Autoimmune hemolytic anemia. This is an acquired hemolytic anemia, which is caused by IgG antibodies. The typical presentation will include anemia that is accompanied by fatigue, chest pains, and sometimes also congestive heart failure. Patients will often commonly present with jaundice because there is hemolysis occurring, which means there's elevated bilirubin, as well as splenomegaly due to the increased destruction of red cells and the increased work of the spleen to clear those red cells. The diagnosis for autoimmune hemolytic anemia includes spherocytes and reticulocytes on the peripheral smear, but ultimately the diagnosis is made by the direct Coombs test, which is positive, meaning that it is an extrinsic issue. Most autoimmune hemolytic anemias are idiopathic, meaning that they have no specific cause. It is common to see them in some other issues such as lupus or lymphomas or leukemias. However, another common cause would be a drug-induced, especially penicillin, and I would encourage you to make sure you remember that one as a potential cause. In penicillin, autoimmune hemolytic anemia, the red cells have an antibody that's attacking them as a result of the drug being present in the system. Approximately 10% of patients with hemolytic anemia will also have thrombocytopenia or low platelets, and this is known as Evans syndrome. The treatment of autoimmune hemolytic anemia involves stabilizing the patient, which is often done with transfusions and/or prednisone. The transfusions will replace the red cells and correct the anemia. However, this is often a temporary fix as the antibodies often attack the new cells as well and cause further hemolysis. Prednisone is used along with the transfusion to try and slow down the autoimmune portion. It is important to remember that as a patient tapers off the prednisone, the hemolysis may recur. It's also important for providers to make sure they treat any other secondary causes of the autoimmune hemolytic anemia. And some second-line options include splenectomy, rituximab, some other immunosuppressives or cytotoxic medications, and possibly IVIG or immunoglobulin. Aplastic anemia. Aplastic anemia is bone marrow failure, and this can be due to some sort of injury to the stem cells, or it can be an expression of abnormal cells. And often the big associations you'll see with this is chemotherapy and radiation and benzene, which is a toxin. And there are some other causes. Many are idiopathic. It can be related to certain drugs or infections. And there's also some inherited conditions that have aplastic anemia associated with them. The presentation for aplastic anemia involves a pancytopenia, pan meaning all, cyto meaning cells, and penia meaning low. So in this case, all cells are low. So you will have a normocytic anemia, neutropenia or low white blood cells, which makes the patient prone to infections, a thrombocytopenia or low platelets, which makes the patient susceptible to mucosal and skin bleeding, and also petechiae and purpura, and you will possibly see hepatosplenomegaly. It's important to realize that in the presentation of aplastic anemia, you should not have lymphadenopathy or bone tenderness. If the lymphadenopathy or bone tenderness are present, then you should be suspecting a neoplasm, such as leukemia or lymphoma. Although you could see a little bit of lymphadenopathy, if the aplastic anemia is caused by infection, it will be short-lived, and as the infection is treated, that will resolve. In the diagnosis of aplastic anemia, the CBC and peripheral smear will show the pancytopenia. Early in the process, it is possible that maybe one or two of the cell lines will only be low. You may not have all three of them in the beginning. And if you have severe aplastic anemia, there will be no reticulocytes. The definitive diagnosis for aplastic anemia is the bone marrow biopsy, and this will show a hypercellular bone tissue. And this is also referred to as a dry tap, meaning that there are no cells and the reserves are completely depleted. The treatment of aplastic anemia involves a referral to a hematologist. In patients with very mild aplastic anemia, meaning that they have not lost all of their ability to produce cells, but they're just low at the time, they can be supported with erythropoietic or myeloid growth factors to try and stimulate the bone marrow to produce more cells. They may also be treated with transfusions of red cells and platelets, and they're often treated with antibiotics to prevent any possible infections. In severe cases, aplastic anemia is fatal if it is not treated. In patients under the age of 40, a bone marrow is the best option, and this is a curative treatment. In patients greater than 40 years old, they can try antithymocyte globulin plus cyclosporin and or a high-dose immunosuppressive with cyclophosphamide to try and control their symptoms, but ultimately this is not a curative treatment. Thank you for listening to the Red Cells and Anemias lecture for the Hematology and Oncology unit for the General Medicine course. Please be sure to have your study guide completed for the application session for this course. If you have specific questions, you may post them on the discussion board under the Hematology Oncology section. Thank you.